So the concepts of booster dosing and dose titration, actually it should go in the other order, dose titration first and booster dosing, uh, involve two different phases of your treatment course. Initially, if you're using a customized LDA antigen, like the Lyme disease remedy, or the yeast mixture, or Crohn's disease mixture, or the skin bacteria, or whatever, if it's one of these customized things, or your own stool or something, there's a very wide range of doses for some of these that we observe the effective dose in for the population. Like with the Lyme mixture, the range of dosing goes from 5C to 30C, which is ridiculous. And a C is a 100-to-1 dilution step. In another video, I'll explain what the nomenclature means so it makes a little more sense with the math. So the initial phase is we have to find the dose that works for you. The gist of this therapy, the way this works, is you have to find that relevant harmonics point with your dosage that resonates with your body in such a way as to correct your symptoms and resolve the immune response problem you have. So there is a right dose. Anything weaker than that, more diluted than that, will have no effect on you. Anything stronger than that will have a negative effect on you, will cause a flare, a worsening of your symptoms associated with that antigen. So what we do that's the safer approach is we start people towards the weaker end of the spectrum. I usually start people 2 or 3 doses weaker than I think they're going to respond at based on my clinical experience. And then we can give them progressively stronger doses every 10 days or so until you see some kind of response. Which means if the first doses have no response, that means they're so diluted and they're so much weaker than your effective dose point that it's okay to give you another dose of the same antigen way sooner than 7 weeks, just 10 days later. And we can go through like 18C, 17C, 16C, 15C, 14C. You can do 5 doses in a couple of months' time, and that's the 7-week period, but we've given all these different doses. The reason you can get away with that is the math. So total dose overdose is an accumulative exposure within a 7-week period. So if somebody's actual effective dose is, let's say, 12C, but you start them at 15, 15 is a million times weaker. So the 15C has no effect at all. You give them the 14C, which is 10,000 times weaker. That has no effect at all. You give them the 13C, that's 100 times weaker than their effective dose, no effect at all. And then they get the 12C, and their symptoms all get better for a couple of weeks. The reason you can do that mathematically is because if you set 12C to be their 100% equivalent dose, or what we call their core dose, then what you gave them was 101.0101% of their core dose. And the weaker doses out on that spectrum are so mathematically irrelevant that it doesn't matter. It doesn't constitute an overdose exposure. The corollary to this is what we call booster dosing. So once you've gone through the dose titration phase and you've identified your effective dose, or what we call your core dose, then you're in a totally different phase of treatment. You have that dose set, and that dose may be repeated every 7 weeks. But that full dose, again, like the 12C in this scenario, cannot be given sooner than 7 weeks, or you will probably flare. It will constitute a total overdose in that time frame. But at this point in time, you can go the other direction safely. So let's say you get the 12C dose and your symptoms all get better for 2 weeks. Well, we can't give you the 12C again because things will be bad, but we can give you a 13C dose. See, 13C is 100 times weaker. So mathematically, it only represents 1% of your effective dose. And you can give that person 1% more of their antigen dose because within that 2-week period, by the time their symptoms have come back, it means that the immune system cells that got the message initially, enough of them died off, because there's always a population of lymphocytes that's dying and being reborn. It's a dynamic thing. It's not like they're all here and then they all move out at the same time, like graduation from college or basic training or something. There's an ongoing curvilinear, attrition of this population. So if you try to match that with small doses of antigen being administered based on symptom return, you can get people's symptoms under better control more consistently and still usually avoid flaring. There is a risk of flaring even when you add just a 1% dose to the person, And the best way to try to minimize that is to make sure that their symptoms have actually come back, that the previous dose truly wore off. Sometimes people aren't so sure. They're like, well, maybe I'm tired today because I went swimming yesterday, but I think it's my Lyme symptoms coming back. So they take another dose, and then that was a mistake, and they flare because it wasn't worn off yet enough. But you can administer these 1% booster doses multiple times until the 7-week date comes around again, and they can have their full 12C dose once again, or whatever that core dose is. So it's a game of ongoing mathematics, honestly. So if your core dose is 12C, but you get a 13C booster dose every 2 weeks, you're going to get, like, let's say 3 of those. So over the course of 7 weeks, that person has gotten 103% of their full dose, which isn't a really big difference at all. But for some people, that's enough to just waste them. And so it's not without risks to do this. But we do it all the time, and based on how long of a period of improvement they got, we gauge what kind of booster dose we can get away with. So if a person gets more than a week of relief from their core dose administration, we usually just give them a 1% booster, which is 1C weaker, a larger number. So if their core is 15, that's a 16C. If their core dose is 10, that's an 11. Okay. But if they only got like 2 or 3 days of improvement, I'll give them a 10% booster dose, which is 0.5C weaker. And there'll be a video explaining what the whole C numbers mean and how to do the math. So if the person got a 12C dose and their symptoms were notably better for just 2 days, then the booster dose I would give them would be a 12.5, which is 10 times weaker. So it's 10% of their dose instead of 1% of their dose. And everything, in my mind, with dose adjustment and booster administration or titration is a game of relative mathematics. When we're doing dose titration for somebody, if they think they may have had a very mild and brief response to something that was positive, I would slow down the titration, and instead of going from 13C to 12C, I would just go from 13C to 12.5C. I would slow down the pace and give them a 10-to-1 dilution step instead of 100. And it's safer to do that. I mean, really, the basis of this is to try to approach the person's ideal dose point in a cautious manner so you get there safely and you don't make the people flare repeatedly. Because if you ever get a dose that makes you worse, you have to wait 7 weeks before you can give another dose, and then you have to back off to something weaker. And the duration and severity of the person's flare helps dictate how much weaker you need to go with the dose, but again, there's nothing exact about that. And it takes a lot more time to flare someone and have to wait than it does to back off a few doses and go cautiously one by one. That's actually more efficient and safer. So that's the concept of titration of the dose originally to find where you respond well. And then the booster dose concept applies when you've had a period of improvement, but it wore off prior to the 7 weeks coming around again. That's when a booster dose is appropriate. So we have some patients saying, I want you to send me some doses to try, and I want booster doses too, because they think they're going to save money or be more efficient. Like, well, we have to explain, you don't even know what your effective dose is yet. You can't have a booster dose because a booster dose is completely relative to what your effective dose ends up being. And some people don't seem to get that. So hopefully this video will explain that and clear up some of the confusion.